Hypomethylating agents are Azacitidine and Decitabine are FDA-approved drugs for treatment of patients with myelodysplastic syndromes. Approximately about 30 to 40% of the patients will achieve a response, and usually it requires about 6 months of therapy for them to achieve the response, which means that approximately about 2/3 of the patient will not achieve a response and commit for a therapy for about 6 months without benefit. So if we are able to identify those patients who will respond to therapy, we may be able then to save cost of unnecessary treatment, as well as improve their outcome. So what we did, we tried to analyze a cohort of patients of 433 patients who were treated at our institution, as well as other institutions such as Dana-Farber Cancer Institute, and received treatment with hypomethylating agents, azacitidine or decitabine plus or minus combination, where we first looked at the genomic panel of 28 genes, and these genes have been described as the most recurrent somatic mutations in myeloid malignancies and MDS. So when we divided our cohort into responders and non-responders and look at the prevalence of mutations among these cohorts, we could not find any significant mutations that predicted response or no response except NF1 mutation. Now, prior reports have shown that TET2 mutations may predict response to hypomethylating agents. We did not see that in our patient cohort. Other studies have also shown that TP53 may be associated with higher response rate. We did not also see that. So what we did then, we took those mutations, we tried to build a multivariate analysis, logistic multivariate analysis that include clinical variables, IPSS score, and mutations, and we could not build any realistic model that can be used in the clinic. So what we did then, we took this patient cohort and we tried to apply machine learning algorithms. And simply what machine learning is trying to run algorithm through computational algorithm and try to define interaction of complex database. So the way we did it, we used the NIME, which is actually advanced analytic platforms that's used for machine learning. So we took the data and then the computer partitioned the data randomly into training and validation cohort. And in the training cohort, we run the algorithm through the computer. So we tell the computer, this is response, this is no response, and then we run the algorithm. And then in the validation cohort, we kind of hide the answer from the computer, and we ask the computer to predict whether this is a response or no response. And then at the end, we have the scoring node, which kind of tell us how many times was the computer right in saying this patient will respond to therapy and how many times the computer was wrong. So we run 5 classification algorithms through training and validation cohorts. And what we're able to build in all of those models, that accuracy rate of predicting response to hypomethylating agents in range of 65 to 67%. But what we did then, we combined the prediction of each model in sort of what we call a bag of model approach, which means that we're trying to get the best out of each model and put it all together in one model. And that's actually enhanced the predictability of the proposed model to 69%. But when we focused our analysis on patients with a higher risk MDS, those patients, usually the ones we treat them with hypomethylating agents, the model accuracy rate improved to approximately 73%. But I think what's really important, we did feature selection algorithms. And the way this is trying to ask the computer, what are the important factors that made the decision of the model to say response or no response? And there is multiple things we can do. So we did backward feature elimination, which means that the computer will eliminate several factors and rerun the analysis, and then we measure the error rate, and we kind of figure out the number of factors that associated with the least amount of error, and that will give us the important factors that the computer choose to make their decision in choosing the model. There's also depth of tree length and others, what we did. And what we found actually, hemoglobin less than 10, platelets less than 30, and age more than 69 were predictive actually of response to therapy. What's really interesting, when we put the mutations as yes and no in the models, the computer did not pick any of the mutations, but when we added valid allelic frequency, 3 mutations came out: TP53, RUNX1, and SIBL, with different valid allelic frequencies, suggesting that we need to include valid allelic frequency when we build the model. So this is kind of preliminary result, just trying to see if this method can be applied to enhance our understanding of genomics. And what we're working now is to increase the number of the patients, as well as use more algorithms and try to do more feature selection to build a reliable model that can be simply used in the clinic.